Hi. Welcome everybody. Yeah, that Professor Hall. It's my honor that Professor Hall give me a chance. To host the Dr. Andrea De Vito's lecture. Uh, I'm the director of the pulmonology of the Sheng-Po Memorial Hospital, and I'm also the chairman of sleep medicine of the Taiwan Society of uh, Respiratory and Critical Care. Med, and Dr. Andrea De Vito is the director of the otolaryngology unit and the deputy director of Department of Surgery at Forlì Hospital, health local agency of the Romagna, Italy. And Andrea De Vito is the recognized expert in diagnosis and treatment upstream for snoring and obstructive sleep apnea. He introduced a new methodology for drug-induced sleep endoscopy in European position paper in 2017. He is an expert in robotic surgery applied in head and neck oncology, especially for the robotic surgical treatment of otolaryngology cancer. And today he will give us a talk about the surgical treatment for sleep disorder breathing from pharyngoplasty to robotic surgery. Because unfortunately, because of the time zone problem, and we will play his pre-recorded lecture video, and let's start the lecture, please. Thanks.
Dear friends and colleagues, first of all, let me thank so much Dr. Sheng-Po Hao for his kind invitation to this virtual webinars for his retirement. I'm going to talk about surgical treatment for sleep disorder breathing from pharyngoplasty to robotic surgery. I really I'm sorry to not online real time due to jet lag, but I'm Andrea De Vito, and I send all my greetings from Italy to the friends of Taiwan and also to all participants in this webinar. I am the EMT director of Forlì and Faenza Hospital within the health local agency of Romagna, a region of more than 1,002,000 people of population. I have no conflict of interest to declare. As we know, the basic factors for apnea events or hypopnea events, which means complete or partial occlusion of upper airways, is due to anatomical factors at the upper airways, but also there are very important also non-anatomical factors such as low airway threshold, a high loop gain, and upper airway muscular impairment. All these factors could be present in the same patient in a single or combined modality, and so the surgeon has to identify the anatomical factor in each patient and understanding if these anatomical factors are predominant in apnea or hypopnea events, because only in this case we could do something of effective from surgical point of view in all the patient. For the patient has a lot of treatment options nowadays, such as CPAP, ventilation therapy, which is the first-line therapy, but there is also a significant percentage of no adherence or intolerance from the patient. But we also have other treatment options, such as upper airway surgery, oropharyngeal, hypopharyngeal surgery, upper airway stimulation of hypoglossal nerve or maxillomandibular advancement. And also we have other non-surgical treatments, such as appliance, positional therapy, lifestyle, diet, and drugs. The candidacy to the surgical treatment started from a careful analysis of deeper study examination, and we have to identify the presence of consistent number of phasic desaturation, and also we have to analyze the relation between this phasic desaturation, which is strictly related to apnea or hypopnea events, and the body position of the patient. And only if there is a predominance of phasic desaturation, it means that the patient have obstructive events during the sleep. And the second step is a clinical examination of our patient, starting from the visualization of oral cavity, analysis of the relation between oral portion of the tongue and the soft palate, the presence or not of tonsillar palatine tonsil hypertrophy, and its grade of hypertrophy. One of the most important diagnostic procedure is the pharyngoscopic examination of the upper airway, by which we have to understand the pattern of collapse at the retroperitoneal region, as shown on the left of this slide, the circular or anterior posterior primary, or due to retroposition of the tongue, or we have also the opportunity to observe a lateral collapse from the lateral pharyngeal wall, also in this case primary, which means due to an intrinsic collapsibility of the upper airway at pharyngeal level, or due to an hypertrophy of palatine tonsil. And the same at the hypopharyngeal level, where we have to observe the presence or not of hypertrophy of the tissue at the base of the tongue, or a retroposition of a muscular base of the tongue, and also its relationship with the epiglottis, which could have an intrinsic collapse, such as the trap door phenomenon, as you can see in the right portion of the slide, or have a collapse secondary to hypertrophy of the base of the tongue. All these patterns are we can analyze very well all these patterns under the drug-induced sleep endoscopy, which is the most important diagnostic procedure in this kind of patients. I think, in my personal opinion, that this diagnostic procedure has to be performed in the best way, which means with the application of the target control diffusion pump, which let us to check the sedative agent concentration at the brain level, and also an analysis of cortical activity by superficial analysis of this activity, which allow us to understand the level of sedation, because we have to put our observation in a stable light level of sedation. Only in this condition, the drug-induced sleep endoscopy can help us to understand the site and the modality of pattern of the collapse at retropharyngeal and hypopharyngeal level. Say that, and if at the end of this diagnostic evaluation, the patient has a treatment option by surgical point of view, we can apply a lot of surgical technique at oropharyngeal level and also at the hypopharyngeal level. At oropharyngeal level means soft palate surgery, and we know that the history of this surgery comes from hundreds of years in Morocco, but in modern era, in 1950, Schwartz applied some surgical procedure for snoring by the resection of the soft palate. And lastly, in 1960 and 1980, Matthew first and Vito after applied this technique, the so-called pharyngoplasty, to snoring and also to apnoic patient. The conventional UPP from Fujita technique is a two-dimensional resection surgery, relatively very demolitive, focused on the middle portion of the soft palate, without to put attention to the lateral pharyngeal wall. And the success rate of this surgery is around 50-60% by shared criteria. One of the main limitations of this technique is that we have, as a consequence, a centripetal scarring vectors which reduce the space, respiration space at the soft palate, so could increase along the time the number of events. This is one reason why in first 2000, Professor Hali tried to introduce a new technique which focused on the lateral pharyngeal wall and not in the middle portion, because the lateral pharyngeal wall is the main structure and has the main role in all the collapse at the upper airways during apnoic events. And after his technique, and other authors such as Pang and Woods concentrate the surgical technique also on the palatopharyngeal muscle, which is cut and pushed laterally and superiorly by suture. The main difference between the conventional UPP and the modern pharyngoplasty is that at the end of the day, in lateral pharyngoplasty or expansion sphincter pharyngoplasty, we have a centripetal scarring vectors which stabilize along the time our surgical result. Starting from all of these concepts and also introduced the so-called barbed suture, Professor Mantovani from in Italy in 2015 introduced the so-called barbed pharyngoplasty in its several applications. And the main difference in this technique is the application of the barbed suture, which is a suture by which we are not we can avoid nodes, and by which we can build a sort of framework inside the middle portion of the soft palate, and also by remodeling palatopharyngeal muscle and the lateral pharyngeal wall. Starting from this, I show our personal, my institution, pharyngoplasty, the barbed remodeling pharyngoplasty, in which we put our barbed suture in a W fashion inside the soft palate, as shown in the pictures, and putting our attention to go around through some important structure, such as raised pterygomandibular and pterygoid hamulus and posterior nasal spine, and also by remodeling and pushing laterally superiorly the palatopharyngeal muscle. In this way, we obtain a stabilized soft palate and the lateral pharyngeal walls, as shown in this 6-month post-op period observation. And this is our first results after 10 years of this technique, where we demonstrate an improvement in more 74% of patients of AHI, the number of hypopnea index per hour. At hypopharyngeal level, it is important site of obstruction, and also at the site we have some surgical techniques to apply. And more importantly, we can apply also robotic technique at the base of the tongue level, which can represent one obstruction really important in older patients. The advantages of Da Vinci system, which is the main robotic system and the robot we have in our institution, is clear to all. I think an excellent exposure of the surgical field, a three-dimensional visualization, and more precise dissection and manual activity, but also a better and faster functional recovery for the patient. We know that there are a lot of generation of robots. In my institution, I have the XI, but also I want to show you one of the latest generation, the single port, where there are a miniaturization of the instrumentation, and this really represent real advantages for the ENT because we can go more deeply in the upper airway surgery with this robotic system. As all surgical technique, also the base of the tongue can represent some point of a potential complication, and specifically the bleeding from a branch of otolaryngology artery. But if we stay in the so-called safe zone, which means the middle portion of the base of the tongue, we can reduce significantly the volume of the lymphatic tissue with avoiding major complication as arteriolingual bleeding. And this video, I showed you only the first part, just to show a case where a really important hypertrophy of lymphatic tissue at the base of the tongue. And just to know this example of robotic reduction, just to underline the importance to stay in the middle portion, and also exactly at the level between muscular plane and the lymphatic tissue at the base of the tongue. This is a 4 hours experience in more than 790 patients since 2008, and at least 50% of the patients are also patients with base of the tongue reduction by robotic technique. And these are all our feature reproduction. And in one of the last systematic review and meta-analysis has been reported that ortho reduction can reach 70% of positive result in terms of improvement of HI, improvement daily somnolence, and also improvement of the lowest O2 desaturation. Obviously, there are also other techniques at the base of the tongue. Historically, one of the first techniques applied in this kind of patient is the so-called Sheng-Po operation, but it has been abandoned because in an open operation, very similar to the supraglottic tracheotomy, with a really long period of admission and really low functional recovery, and so. In my opinion, in my experience, it was a technique to apply in this kind of patient. The decoblation application is a really effective alternative, but we have to consider that we are not a direct visualization as a robotic organization technique, and so the risk is that when maybe we can remove a little less portion of the lymphatic tissue with less potential improvement in HI terms. In any case, we have to consider that the surgery is one of the treatment options for the patient. So we have to have the mentality to consider our patient in a multidisciplinary and multimodality way. So if CPAP has a failure, surgery can do something to improve the tolerance of CPAP, for instance, reducing the collapse at the epiglottic space or nasal resistance at the level of inferior turbinates. or maybe massive oral appliance would improve partial success from surgery. So the paradigm one size fits all. So one treatment can resolve only all the problems in other patients, not true. And this is some of latest literal data from my group and also international collaborators. And greetings from ENT for the teams. And but let me to thanks again Peter from the friends. I am honored to collaborate with him along the time with some papers and the book on laryngeal cancer and some roundtable at the American Academy. So thank you so much, Peter, for your collaboration and your friendship. And last but not least, Peter had a really impressive lecture to my latest ENT for the workshop on 19th October. And so I'm more than sure that our collaboration and overall activity of Peter will be continued, even though he's retired. So thank you again for your attention, and please send comments, suggestions, questions at my email written. Thank you so much.
Thanks for doctor's talk. And if anyone has any question, please send the email to Dr. Andrea's email address. And that's the end of today's talk. And thanks for everybody's attending.
Yeah, so thank you, Andrea, for a wonderful talk. And also thank you for Chip Lin for your moderating the section. Also, we saw a lot of, participants from all over the world to listen to Andrea's talk. So maybe we could have some comments from the floor, some comments from the participants. I guess, we only allow for comments. But any questions or any other specific questions, especially please send to Andrea, Dr. Andrea De Vito. Yeah, and so is there any comments from the floor?
I'm Inshou Xu here, and I congratulate the Professor De Vito's talk, and I'm hopefully because there's a single port robotics demonstration in the video, so I'm anticipate in our new hospital maybe we can try the single port robotic surgery in the future. Thank you, Professor Host, inviting and Professor Chamolin's hosting. Thank you very much.
Thank you. Is there any other comments from the floor? Is there anything? I think this is the cutting edge, management of the sleep apnea, and talk about something like how to make a correct diagnosis and to determine the level of obstruction by way of the endoscopy, drug-induced endoscopic examination, and then apply the surgery. However, I think CPAP maybe still the first treatment. So is my comment correct? I would like to ask Lin Jiamo, Chip Lin first. Is CPAP is still the yes? Please comment.
Yeah. I totally agree that the Professor holds the opinion that because that that's the problem because the sleep apnea patients their obstruction point actually in Taiwan that a lot of them has the has allergic rhinitis, and also that as time goes by, some of them has the obesity problem, and some of them because of the because of the anatomy or that the aging also has the muscle weakness and also has some obstruction point. So from the nose to the upper airway, that there's a lot of the obstruction point, and also I believe over 50% of the sleep apnea the patient all in Taiwan all has an allergic problem. You also need to control the allergy. So for them, it's very hard to only operate some obstruction point, and then and then you can solve the sleep apnea problem. So for I think CPAP maybe and CPAP and also the allergy control, yeah, for the most sleep apnea patient, I think it's the most important. And for for selective patients like the huge tonsil, deviated nasal septum, and some anatomy really has some anatomy problem, then I think the surgery may be suitable for that. But I think only you need to select the patient and do the very good pre-operation evaluation. Thanks.
So that's the opinion from the pulmonologist, from the internal medicine doctor. Is there any comments from the surgical side? That means is there any surgeon love to comment on this? Perhaps Ye Ruiming. I saw Dr. Ye in the in the audience. Or any other want to comment on this? What's the law of surgery, really?
No, I have no comment.
Yeah, so you agree 100% what Dr. Lin Jiamo said.
Yes.
Yeah, so what we observed in the clinics is that even after some delicate surgery, there are still patient, their symptom will come back, either in a short term, in 2 or 3 years, or even after 5 years, their symptom will come back. So I think the lifestyle change, as well as the maintain the good behavior, and also weight loss might be as important as surgery. So I guess it's I just want to echo what Andrea said. It's really a multi-modality treatment, not only for surgery only, although surgery could be a very good option to treat the obstructive sleep apnea. So if there is no other comments, I would love to say thank you to Professor Andrea De Vito and also Professor Lin Jiamo for moderating the section. And just some advertisement for the for the further educational webinar. We are going to have next week. We are going to have my past fellow Jennifer Ameno Alaga from Philippines again, and to deliver another talk. And then we have Dr. Pesoput, but that's from Thailand. He will talk about epidemiology driving change, preventing and controlling head and neck cancer. The experience, I think, in Thailand, which might be just very wonderful. And then we have another Miles lecturer that will be on the third week in December. Dr. Rain Neiman, his quality of care in head and neck surgical oncology. He Dr. Lehman was the Miles lecturer 2 years ago, and so we look forward to his talk. And at the end of this webinar series will be my best friend, one of my best friends, Professor Hong Kim, the father of head and neck surgery in Korea. He will talk about the voice problem related to thyroid surgery. So that's the end of the whole 9 months retirement virtual webinar. So thank you again for a wonderful lecture delivered by Andrea De Vito and also Dr. Lin Jiamou's moderating, and also all the participants. And hope you have a good day. Thank you. Bye-bye.
Bye.